How old Popeye is this year? He's 84 years old. So I know he was around, and every one of us was a little girl or boy. How many people like Popeye? Did you watch me like him? Okay. You liked him, really? All right. So Popeye is up here because when Popeye got in trouble, he reached for his what? His spinach. Spinach is a dark green leafy vegetable. To be honest with you, I think Popeye was a ploy to make us eat our vegetables when we were little kids. I really believe that. But dark green leafy vegetables tend to be an example of a food that is rich in iron, as are these other examples. Here in South Louisiana, we love red beans and rice. Red beans is a good source of iron, but people eat, obviously, other types of beans and peas around the United States. So here's what I want you to be clued in on. Suppose you see a question on the exam about a vegetarian who's iron deficient. A vegetarian is not going to eat an organ meat or red meat. You may recommend lentil soup or any of the other things on here, all right? So have an idea of what you would recommend food-wise for someone who doesn't eat the traditional foods that are high and rich in iron. Everybody with me? So one way to get patients with iron deficiency anemia to feel better is to get them to eat foods that are rich in iron. But you know what you ultimately have to do? You got to give them one of these supplements. So how do you know which one you're going to pick? Oh, Amelie, I'm going to give them my precept I always gave. That's not a good enough reason. Which one are you going to give? Let me make sure you know about iron preparations. First of all, in the United States, you have three choices when you prescribe iron. You could give ferrous fumarate, but most people don't. You could give iron gluconate, ferrous sulfate, but here's what you should remember. When a patient has iron deficiency anemia, the amount of iron that we replace them with is 150 to 200 milligrams of elemental iron a day. So let me tell you why most people don't know this. Elemental iron is not how much iron is on the box. Take a look. When we look at ferrous fumarate, 325 milligrams, the amount of elemental iron is 106 milligrams a day. This one is very poorly tolerated, so we rarely give it. The form of iron that we probably give the most to people who are non-pregnant is ferrous sulfate, because the box says 325 milligrams of iron. You know how much iron they really get? 65 milligrams of elemental iron. So do you realize, without making this a math problem, that they don't need one of these a day? If you need 150 to 200 milligrams of elemental iron a day, how many of those a day do you need? About 3 of them. You got it? So don't get tricked by the number on the box. You must look at the number of milligrams of elemental iron, and that's what tells you how much to prescribe. Now look at the last one I didn't talk about, ferrous gluconate. We use that a lot in pregnant women. How come? Because it's the best tolerated. It does provide the least amount of elemental iron. But what symptoms do we see in people who take their iron? Constipation, sometimes heartburn, nausea, right. So, excuse me. So anyway, ferrous gluconate, do you realize how many of these a day they'd have to take? Like about 8 or 10 of them? Yeah, so you see why we would bump it up to ferrous sulfate if we had to treat with 150 to 200 milligrams a day. Is everybody with me? Do you see it? Do you know which iron to prescribe now? All right, let's see if you know. This is actually one of my patients who is a nurse. A 24-year-old female has iron deficiency anemia. She's taking 200 milligrams of elemental iron a day. Good. She asks you, hey, Amelie, when should I expect to feel better? Excuse me, I'll be right back. I don't know when you're going to feel better. When do they feel better? Why do you know when they feel better? Let me show you something. She's going to begin to feel better in about 2 to 4 weeks. Here's how I know, and you do too. The minute we begin to give her iron, her bone marrow is going to begin to shoot out what? Reticulocytes. So for 3 to 10 days, once we give her iron, she is going to be in high reticulocyte production. Those will mature day by day by day, and we'll observe an increase in her hemoglobin and hematocrit in 2 to 4 weeks. When her H&H goes up, the patient will feel better. You got it? So when she says, Amelie, when am I going to feel better? Oh, about 2 to 4 weeks. Some poor people with iron deficiency anemia are so deficient that in 3 days or a week, they'll tell you, I feel better. I'm not where I was or where I need to be, but I feel better. But generally speaking, 2 to 4 weeks, they will see a noticeable difference in the way they feel. Now, how long do you have to keep them on their iron? I would tell you that we typically replace their iron for 4 to 6 months. And let me make sure you see the point, and this question will give it to you. Here's your patient. A 34-year-old patient with iron deficiency anemia has taken iron supplementation for the past 4 weeks. I'm thinking she should be feeling better, and you should see an increase in H&H, right? 4 weeks ago, H&H 31 and 10. Symptomatic, I'm sure. 4 weeks later is today. Hemoglobin's gone up 0.2. Crit up 0.8. Well, you know what would be really helpful for you to know? How much should you expect her crit to go up in a month if she's really taking her iron? 3 points. Crit ought to go up 3 points. Hemoglobin ought to go up 1 point. They didn't hit it. If she's really taking this iron supplementation, or you like feeling not so good about this, what's the most common reason for anemia? Blood loss. You did a stool for occult blood, negative times 3. What are you thinking? Are you thinking happy thoughts about this lady? Because I'm not. What do you want to do? You know what I really want to know? When she takes her iron, is she making reticulocytes? What are you going to measure? You're going to measure reticulocyte count. If the reticulocyte count is elevated and she's popping out reticulocytes, something is causing those reticulocytes to lie. She's got a problem. She needs to see hematology. If she's not making reticulocytes because the count is not up, what are you thinking? A sick bone marrow. You follow me? All right, so what do you get? You order reticulocyte count. I'm not feeling the love in this room about reticulocyte counts. All right, so what are we going to do? You look for people who are at high risk of iron deficiency anemia, and this list includes them. One thing I want you to consider is that NSAID users are going to be at highest risk. Thinking GI bleeds. What common NSAID does nearly every older adult I can think of take every day? A baby aspirin. So listen, let me tell you how GI bleeds go. GI bleeds go like this. Drip, drip, trickle, trickle, psh. That's how GI bleeds go. You know who's least able to sustain psh? An older adult. A young or middle adult, I'll put my money on. An older adult who has a big psh may not survive a GI bleed. So when you see a reduced H&H in an older adult, your brain ought to be on, is this patient got a GI bleed? All right? Be all about it. Thalassemia. Question on the exam, right, Amelie? I'm thinking, yeah, maybe. So listen how thalassemias are described. They are microcytic and hypochromic. Small and pale red blood cells. This is extremely common. In fact, it's the most common genetic disorder in the world. That's the most common genetic disorder in the world. And there are different types of thalassemias. Please don't memorize them. But generally, we have beta thalassemias, we have alpha thalassemias, and in all of these people, we need to make sure that they're not inappropriately exposed to iron. All right? That's the whole deal with the thalassemias. We don't want to load these people up on iron, so hold on to that thought. I want to know what differential diagnosis should be included in a patient with suspected thalassemia. What am I really asking you? What other anemia is a microcytic hypochromic anemia? Iron deficiency. So when you see a patient with a microcytic hypochromic anemia, the most common one is iron deficiency, but you must always have thalassemia in your differential. So let me bring this up. When a patient has iron deficiency anemia, what do we load them up on? Iron. When a patient has thalassemia, what do you never load them up on? Iron. So you have to be able to distinguish these two people who both present with a microcytic hypochromic anemia. How can you do that? It's very simple if you know what to look for. This is what you look for. If the H&H and MCV and MCH are the only thing you look for in these patients with iron deficiency, anemia, and thalassemia, you're going to miss the thalassemia patients. They look exactly alike. But here's how they differ. In your patients with iron deficiency anemia, their iron measures are out of whack. In a patient with thalassemia, they don't have an iron problem. Their iron measures are all, normal. The RDW in a patient with thalassemia, their bone marrow spits out the same size red blood cell day after day after day. That's not true of a patient with iron deficiency anemia. Look at the serum iron. Who's that low in? An iron deficiency patient. Thalassemia patients don't have trouble with iron. So that's how you differentiate these two people, and that's how you know who to load up on iron and who you better not load up on iron. Hey, Amelie, suppose I really didn't know this or learn it. Like, this is getting kind of hard. I don't know if I'm going to learn it. Nobody's thinking that, huh? Okay, good. Suppose you're thinking, how am I going to differentiate these two people? Because you know what? If you just load everybody up on iron, the odds will be with you, because most of them have iron deficiency. But when you load up the wrong patient, and they have thalassemia, and you load them up on iron day after day, and then they don't see you anymore, and they keep taking iron because it's over the counter, what do you do with your extra iron? You store it. Where do you put it? You store it in your liver. How much iron does it take to get a liver hepatotoxic? I don't know. That's the problem. I don't know. So do you see the problem? You've got to give the right person iron, which means you have to be able to identify who's got thalassemia, because you don't want to load those people up on iron. Everybody with me? All right, so look, easy question for you now. What advice should be given to female patients who are diagnosed with thalassemia? Don't be taking iron on your own. Somebody needs to be monitoring you, right? So how about number 2? Avoid excessive iron. In fact, it's the same instruction we would give if it was a man. All right, so number 2. Anemia of chronic disease. Emily, we got to know this one too. Yeah. You're going to see so much anemia of chronic disease, you never believe it. So let me show you another name for anemia of chronic disease. It's sometimes called anemia of chronic inflammation. It also is anemia that we see sometimes with occult malignancy. So look at how this anemia is described. The red cells are normal size and normal color. What do we say? Normocytic, normochromic. That's what the red cells look like in patients who have anemia of chronic disease. Amelie, I don't get it. Why do they have a problem? Because there aren't enough of these red blood cells. Well, how come? Let me tell you what happens with anemia of chronic disease. When you woke up this morning, you woke up as a human being. Suppose today was not your lucky day. When you woke up, you woke up as a red blood cell. And you got put in somebody whose blood sugar is 300 on a good day. Do you realize what a hard life you've been given? Listen, think about what a poor red blood cell has to do every day. They have to swim through these dark little tunnels called blood vessels. When the blood is very thick and sticky because your glucose is 300, do you realize how much work red cell has to provide to move along? Do you really think that red blood cell is going to live a normal life? Because I don't. They don't either. A normal red cell lives about 100 to 120 days. When you stress red blood cells like that, because they have anemia of chronic disease, they only live 2 to 3 months. They die early. The problem is that we don't get enough red blood cells. The bone marrow just can't keep up. You got it? That's what anemia of chronic disease is. And so, it's something I want you to see. It's too savvy for your exam, but you've got to know this for your practice. Both iron deficiency anemia and anemia of chronic disease can present with a low serum iron. Don't you dare take the bait. When you see a low serum iron, don't you dare say, this must be iron deficiency, let me load them up. If you have anemia of chronic disease, your other iron measures are going to be normal. This patient will not get better. Their anemia will not be corrected if you give them iron. They don't need iron. The person who needs iron is somebody with iron deficiency anemia. If you just happen to throw in a SED rate and you measure a SED rate, what is very common in a patient with anemia of chronic disease is that the SED rate is elevated. Because what was the other name for anemia of chronic disease? Anemia of chronic inflammation. So this is a clue to you not to give iron. but to go looking for something else going on with this patient. Everybody see it? So don't take the bait when you see that low serum iron. I want you to think about a patient who's got maybe anemia of chronic disease. All right, let's see if you got it. Look at my question. A patient's H&H is 10 and 30.6. Do you agree they're anemic? Absolutely. Which findings are consistent with a normocytic, normochromic anemia? What you looking for? A normal MCV and a normal MCH. Which one is it? It's not number one because 38 is not normal. I'm thinking, how about number three? How about number three? So how do we get a patient with anemia of chronic disease better? We don't give them iron. We don't give them B12. What do? We get better control of the underlying disease, and let me show you what will happen. If someone comes in with anemia of chronic disease because their chronic disease is diabetes, or let's say it's diabetes, and their A1C is 10, the minute you move that A1C down to 7, to 6, you know what happens to their anemia? It evaporates. It goes away. So how do we help manage people with anemia of chronic disease? You get better management of the chronic disease. Whether the chronic disease is hyperthyroidism, whether it's lupus, it's scleroderma, it's rheumatoid arthritis, once you get better control of the underlying disease, the patient's anemia will go away, unless they've got an occult malignancy. You got it? Because occult malignancies present with anemia of chronic disease as well. Is that scary? It's very scary, right? You never want to miss a malignancy in a patient. All right, let's switch gears. You ready? Let's talk about these macrocytic anemias. Macro means what? Big. Right? Huge red blood cells. And what two deficiencies do we see? We see B12 and folate deficiencies. These are vitamins. So when patients have a macrocytic anemia, you know what they have? A vitamin deficiency. That's exactly what these people have. So what makes people have big red blood cells? Well, I'll tell you right now, it's if they don't get enough B12 or folate. But there are two groups of people who are particularly susceptible to these types of anemias. You know who they are? One group of people is elderly patients, because as each of us ages, we absorb less B12 and folate because the pH in our stomachs rise. And you need an acidic pH environment to absorb B12 and folate. But the other group of people who end up with a B12 and folate deficiency are people who get their calories out of a bottle. And I'm not talking about the kind with a nipple on it. I'm talking about the bottle that is nestled in a brown paper bag and held affectionately under the non-dominant arm. And you can't pull that bottle away even when they're sleeping on the street, right? That's who I'm talking about. So we always think of alcoholics as being people that have macrocytic anemias, but look at all the people who might come to see you because they've got a macrocytic anemia. So there are some things in this world that just kind of go together, like salt and pepper, peanut butter and jelly, Saturday and Sunday. Well, there's another pair that I want you to put together. It's B12 and folate. Anytime you order a B12 level, you better order a folate level. Those two deficiencies seem to run together. And if they're deficient in one and you don't correct it, you'll never correct the other one. So you got to make sure that both of them are corrected if they're deficient. Look at my question. I want to know what in the world would make you suspect a B12 or folate deficiency. A 65-year-old patient has suspected B12 and folate deficiencies. What typical symptoms might he exhibit? What you thinking? Excuse me. What's B12 do for you? Helps red blood cells mature, and what else? It's responsible for good nerve health. What nerve? If you're an older adult, it's the nerve between your ears. Brain. In a young or middle adult, if you have a B12 deficiency, what symptoms do you exhibit? Paresthesias. It's typically peripheral nerves, right? So what symptoms most common? I would tell you number 3, unexplained weakness always buys a B12 and folate level. All right, so number 3. So that's how they present. To be honest with you, For 10 years, people with B12 and folate deficiencies are usually asymptomatic. It's very unusual to have them come in with fulminant symptoms, and if they do, they've had it for a darn long time. So all of these people are people who can have B12 and or folate deficiencies. And so how do we get them better? Well, if they're deficient, what do? You give it to them. B12's best way to get incorporated into you or your patient is by injection, all right? Folate or folic acid you can take by mouth, and here's just an FYI for you. I told you these were both vitamin deficiencies, right? Folate is a vitamin, but when you supplement them, you don't give them folate, you give them folic acid. You got it? We can't give folate by mouth. You give folic acid, and it provides them with folate. So, FYI. You know what? I like to treat these anemias, even though I don't see them that often. You know why I like it? Because in a week, these people feel better. They need treatment a whole lot longer than that, but to be honest with you, they begin to feel better in about a week. Reticulocyte counts go up, and what happens to the anemia? It begins to get dissolved as more red blood cells are incorporated into the bloodstream. And I guess one of your final points is that if you have a patient with B12 deficiency, they need lifelong replacement. You got it? So we correct the anemia, but they continue to get their monthly B12. Not the case with folate, right? Once you correct it, you don't have to continue to give folic acid, but since it's a water-soluble vitamin, often people continue to take it because you can't get toxic on that. What happens if you take in loads of a water-soluble vitamin? You have expensive urine, right? That's about what it amounts to. All right. Have y'all started to get curbside consults yet? Like your friends, your family stop you. Hey, Amelie, what about this? Hey, what about that? I'll tell you a quick story, I guess. Take a look at this patient. A patient exhibits these lesions on his feet. Like, you might be a new NP, and you look at those lesions, you might not know what they are, but that's not normal. This is one of those, excuse me, I'll be right back, right? So here comes somebody whose lesions look like that. First of all, what are the lesions called? The little dots are called petechiae, and when you have so many petechiae that they coalesce, we say you have purpura. So what you're looking at there is petechiae and purpura. Now, what is that significant for? Bleeding, right? An extravasation of blood under the skin. That's what's caused it. What lab would you order to let you know about this problem? A CBC. And what are you looking for on a CBC? A low platelet count. A low platelet count is called thrombocytopenia. Penia meaning you're poor in platelets. And usually the rest of the CBC is normal. By definition, a platelet count less than 150 means you have thrombocytopenia. So that's the number that we look for. And what could make somebody not have enough platelets? Well, maybe they have a sick bone marrow and it's not producing it, or maybe the bone marrow is producing it, but something else is making their platelets die very quickly, like a disease like lupus, or maybe a drug that's on board. Your job is not to figure it out. Your job is to recognize thrombocytopenia and realize, I got to get this patient into hematology, which is going to be your job. You're going to punt when you find this and let somebody else work them up. So let me introduce you to this term. This term is ITP, idiopathic thrombocytopenia purpura. You know what that means? It means you spent $10,000 or $20,000 trying to figure out why they're not making platelets, so they don't have enough, and you couldn't figure it out. So you know what the hematologists do, huh? The oncologists? They spend all this money trying to figure out why the patient doesn't have enough platelets, and they can't. And instead of saying, I don't know why you don't have enough platelets, Ms. Boudreau, they say, Ms. Boudreau, you have idiopathic thrombocytopenia purpura. What does Ms. Boudreau say? How long do I have left, right? So ITP, you'll probably use that again. All right, so there we are. We have talked about red cells and white cells. Red cells and platelets. We need to talk about white cells. And so it brings us to our topic of leukocytes. If you were well today, the white cell that ought to be present in you in the greatest quantity are your neutrophils. Look, every 60 to 70 white cells that the lab finds in you are going to be neutrophils. Another name for neutrophils are segs. Another name is polys. So whether we're talking about newt, segs, or polys, we're talking about the same exact white blood cell. The white cell that ought to be present in the second greatest quantity if you were well today are your lymphs. 20 to 25 of every 100 white cells are going to be lymphs. Another 3 to 8 of them are going to be monos, maybe a basophil, and probably 2 to 4 eosinophils. When you add them all up, it ought to add up to 100, which is why that percent sign is there. Now, let's take a look. If you interpret CBCs and you're a whiz, keep doing what you're doing. If you struggle, let me show you what I do and it might help you. When I get a patient's CBC back, the first thing I typically do is look at their total white count. In this patient, it's 7.9. According to this lab, that's normal. The very next thing I do is go down to see what white cells the lab found. That's your differential. So what I do is I do a really quick addition. I add these numbers up right here in my differential, and they better add up to 100. It's okay if it's 99 to 101, but it better not be 108 or 93. Something is wrong with that specimen if the differential doesn't add up to 100. After I've done that and I realize, yeah, this is 100, I'll look at what cell the lab found most of, or found first. They are listing polys, 46.5. You know what the lab is telling me? Amelie, we didn't find as many as we thought we would find compared to the lab norm. So we're low in polys. Lymphs, they found more than they thought they should have found, 43.1. You will never find this in a book, but I'm getting ready to write a lab book, and I'm going to put this in it. Anytime the polys and lymphs are close together numerically, I want you to think viral. Anytime your polys and lymphs are close together numerically, I want you to think viral. And I'm thinking viral in this patient. What else should you know about your polys and lymphs? You should know that your polys and lymphs are your first responders. They're like the EMTs. They're right on the scene. In fact, within 2 hours of your getting sick, your polys and lymphs are going up or down. All right? Within 2 hours. Simply because these are your first responders. And they'll go up or down whether it's viral or bacterial. Look at the next white cells the lab found. Monos. Monos, they found 10.2. They found more than they thought they were going to find. Why? Well, what do you need to know about those monos? Here's what you need to know. They are wonderful white blood cells. I love them, and you do too. The monos don't come to your help when you get sick for at least 24 hours. So right now you ought to be thinking, oh, if the monos are elevated, it means the patient's been sick for longer than 24 hours. So it tells you how long the patient has been sick. The next white cell the lab found for me were eosinophils, 0.1 normal. What does that tell me? Well, I know that I see elevated eosinophils in two common conditions. One is allergic reactions, and the other is parasitic infections. Right? So those are the two times we see it. These are normal. Basophils, normal. They don't tell me a whole lot. Well, they do sometimes, but not in this case. So what do I know so far? My money is on a viral infection that's been there for greater than 24 hours. After I look at my white cells, now I go up and I go get my red cells. My RBC count, normal. Hemoglobin and crit are low. Do you think the patient's anemic? My money's on yes. What do his red cells look like if he's anemic? Well, I'm looking at an MCV that's microcytic. I'm looking at MCH that's hypochromic. So we have a microcytic hypochromic anemia going on. What's in your differential? Iron deficiency, thalassemia, maybe anemia of chronic disease. I don't know which one it is, but I know which one is not. I know which microcytic hypochromia anemia is not. Look at your RDW. I know this cannot be thalassemia because thalassemia, what's your RDW? It's normal. Iron deficiency anemia has 1 greater than 15%, and that's what this is. I'm a betting girl. I'll put $100 on the table. This is iron deficiency, but I'll be honest, I do not know until I get my iron studies. So look at what you know about this patient. A microcytic hypochromic anemia that is not thalassemia. A viral infection greater than 24 hours. What are you thinking? Thinking that's a lot to know about this patient. You got it? All right, let's keep going. Here's your next patient. Total white count, 15.9. It's kind of a lot of white cells running around somebody's bloodstream, right? Let's go see what quantities they found of them. Go to your differential. Polly's 81. Whoa, that's a lot. Lymphs, 2. Numerically, help me. What are they? Far apart. When they're far apart, Amelie's brain says, consider bacterial, and I am. Monos, 14.9. Then we'll get out of bed for 24 hours. We got a lot of them. What does this tell you about how long the infection's gone on? Greater than 24 hours. EOs are normal. Okay, wait, bands. What are bands again? Bands are immature white blood cells. Okay, wait. Where are immature white cells supposed to be? In the bone marrow until they mature. Well, wait a minute, Amelie, I thought you told me that the bone marrow was on 24-hour patrol. Well, what's it doing letting out immature white cells? Well, here's what's going on. Your bone marrow is on 24-hour patrol. It spots a bad pneumonia. Oh, man, that's a terrible pneumonia. What goes out first? Polys and lymphs. And the bone marrow sends out polys and lymphs. And it's watching how they're doing. Come on, monos, get up. I need you. 24 hours later, the monos finally start to get out. The bone marrow's looking. Oh, man, they need more help. Bands. You're the best I got, but you're not very good. You need to go. Go, bands. So now the bands go out. So when you see bands in central circulation, it tells you the bone marrow thinks it's a bad infection. You don't know if it's bacterial or viral. You just know it's a bad infection. And in fact, that's exactly what you ought to think with those 2 bands. All right? And it's still going to add up to 100. Now go back up and get your red cells. RBC count, low. Hemoglobin, low. Crit, low. You know what? This patient's anemic. What do his red cells look like? Big. Macrocytic red cells, right? Normochromia. What's in your differential? Macrocytic. The 2 common ones, what are they? B12 and folate, right? So what's your next set of labs you're going to order? A B12 and folate level, exactly. So what's your interpretation? My interpretation is bacterial greater than 24 hours. My interpretation is a macrocytic anemia, but I don't know which one, but it could be both. So I need a B12 and folate level. You got it? Really quick question.
So the MCV and the MCH don't have to be elevated for it to be a macrocytic anemia?
No. A macrocytic means size, so only an MCV has to be big. The MCH with a macrocytic anemia is usually normal. So this is a typical macrocytic look, all right? So no, they don't have to both be big or elevated. Last CBC, here it is. What's your interpretation? Total white count, normal. Go down to your differential, adds up to 100. Polys, 90. Lymphs, 8. Wait, hold on. Amelie said when they were far apart, think bacterial. But if this was bacterial, wouldn't you expect your total white count to be higher than 6.2? I would, and you should too. Let me give you a good pearl. Patients should always look like their blood work. This looks like a bacterial infection. When patients don't look like their blood work, you need to ask more questions and or repeat or get more labs. You got it. Patients should look like their blood work. When they don't, you got work to do. So listen, what might account for CBC to look like that? Suppose a patient came in and told you this tale. Amelie, when I went to bed last night, I felt fine. At 5 o'clock this morning, I woke up with a razor blade sore throat. I can't swallow my own saliva. I'm having to spit it out in tissue. You know what? If he woke up like that at 5 o'clock and he's your 8 o'clock appointment, he looks like his blood work. If you were to recheck these labs at 7 o'clock tonight, his total white count will have gone up. So you may have gotten this lab work at a very early clinical presentation. That's one account of this. Another possibility is that this patient is never going to mount a big white count because he's immunocompromised. You with me? So that's certainly a possibility. So again, you must look at how the patient looks and see what's what. But patients ought to look like their blood work, and when they don't, you got questions to ask. Whew. Take a big deep breath. Amelie, this is really hard. I know it is. You got to know a lot to be an NP. I have just a couple of questions for you. Let's take a look and then we'll take a break. A patient's H&H is 10.6 and 32%. Do you agree that they're anemic? Yes. Which findings are consistent with thalassemia? What are you thinking? I'm thinking I need a microcytic hypochromic anemia. Which one is it? Is anybody thinking number 4? Everybody see it? Okay, good. A patient has anemia and the following lab values. I just tell you they're anemic. What's most likely diagnosis? I want to know what you diagnose this patient with. So take a look. MCV is 72. Look at your norm. What word do we use to describe that? Microcytic. Look at the MCH. Low. What word do we use to describe that? Hypochromia. Serum iron is low, but wait, that's the one where she said don't take the bait. Go look at the rest of your iron studies. TIBC, what did we say? That was an egg carton, right? When the count is low, the TIBC is elevated. Serum ferritin? Oh, they don't have a lot of iron in storage. What is your diagnosis? Iron deficiency anemia, right. Listen, why isn't it anemia of chronic disease? Because iron is abnormal, and it's a microcytic hypochromic anemia. Why isn't it number 3, thalassemia? Thalassemia is microcytic and hypochromic, but thalassemia has normal iron, right? This is abnormal iron. Why isn't it a folate deficiency? That's a macrocytic anemia, and this is microcytic. Everybody see it? All right, so number 1 is your best answer. A 72-year-old male patient has been diagnosed with anemia. He has the following lab values. And he's been feeling tired for the past few weeks. So you have an older patient with an anemia who's symptomatic. What anemia is part of your differential? Well, look at your patient. His MCV is 112. What does that tell you? Macrocytic. Big. Look at his MCH. Normal. You see how normochromia follows? So macrocytic, normochromic, serum iron normal, TIBC normal, serum ferritin normal. Is this an iron problem? No. What do you think this patient has? They have a macrocytic anemia. What's in your differential? B12 and or folate. My money's on, how about number 2? Everybody got it? All right, hey, we're there.